Good evening, everyone. Let's start
Yeah.
our mixed FIVA and oral radiology cases. Candidate 1, are you ready?
Yes, sir. Yes, sir.
Welcome. For this is this patient is 20-year-old female patient complaining of long-standing lower pelvic pain.
Okay, sir.
Can you request control?
Yes, sir.
Request to leave.
Yes, sir. Okay, sir. So here I'm provided with T2 weighted eggshell MRI images of this patient who has presented with long-term pelvic pain. Um,
Okay. Yes, go on.
yes, sir. Okay, so I will just quickly go through the entire stack of images before giving my final comments. Okay. Um, so uh, I can see that s- okay. So the images are jumping very fast. So, so like, can you scroll, sir? Because if I'm trying to scroll, they are very jumping very fast.
Okay.
Yes, sir.
No problem.
Thank you. Yes, sir.
Let me
So,
add the slice of interest for you.
yes, sir. Yes, sir. So I'll just quickly go through the entire stack of images. Okay. Um, so on these images, I am not able to see any significant finding. Yes, I can see that left ovary is appearing normal. Checking the right ovary. Okay, right ovary is also appearing normal. So I would like to see the uterus. I would like to see it better on the sagittal images if available for this patient. Okay, looking at the uterus, I noticed that the uterus is retroflexed. The uterus is retroflexed, and okay, yes, the endometrial stripe appears normal. The junctional zone is also not widened. And okay, I think okay. So rest of the okay, the pouch of Douglas also is appearing normal. I'm not able to see any altered signal intensity areas in the interior wall of rectum. Um, so can I have a look at the coronal images?
Okay. This is the coronal imagery.
Okay, so okay, on the coronal T1 weighted images, okay, I'm just checking uh, to I will check the bilateral ovaries to look for any altered signal intensities in the bilateral ovaries. Okay,
Don't worry about the others.
okay, sir. So, sir, on okay, sir, okay, sir, yes, rest of the bowel loops and yeah, visualized bones are also appearing normal. So, okay. So yes, even the I'm not able to see any other altered signal intensity area in these images. So
Look
can I
here.
have
Look here. Look in this slice, please.
mm, okay, so okay, so in
What
this
happened
slide,
here? What happened? Can you scroll this few adjacent slice specifically?
uh,
By the way, my colleagues, today's session is about the importance of how to scroll by yourself and the importance of orthogonal or MPR views. In another word, you will your finding you will find it either by scrolling or by asking other MPR. So in the exam setting, uh, 99% you will scroll through yourself because everything is ready. Don't worry. Okay. not like here,
Okay,
sometimes
so
jumping. Mm.
so I'm not able to find any significant finding in these images. So can I have a look at the other star images as well, like
Okay.
just to have a look? Or yeah. If the patient has undergone any other investigation prior to this, any ultrasonography, if available for this patient, I would just like to have a look before, like if there were any significant findings which might be of
What do you
relevance.
think? What do you think it is acceptable to request ultrasound pelvis after MRI?
Okay, so um,
Again, when the examiner
yes,
told
sir.
you or give you, leave the mouse,
Yes,
give
sir.
you a suggestion, please, he actually helping you. Concentrate here, please.
Um, so in this, I'm able to see the urinary bladder. Urinary bladder is appearing normal. Um, And yes, rest of the visualized bobble loops appear normal surrounding. I'm not able to see any signal or intensity changes in the visualized bones. So, so I'm not able to find anything. I mean,
What
on
is your
these
next
images.
step? What is your next step?
So I would like to see the other images, like if any stirred images are available or diffusion weighted images are available.
If I
Okay.
told you, do you want to revise any old studies?
Uh, yes, so probably I would like to have a look at the sagittal reiterated images again.
What is this?
Okay, I think, sir, yes, I think these are the, okay, I think these are the, okay, this is a blood, I think these are the bobble loop stretch.
What is this
This is,
linear shadow or linear signal, dark signal? What is this?
is this a strictured segment of the bobble loop, sir? I'm just suspicious, like, if there is some stricture.
What do you think?
Okay, sir, okay. Yes, sir, this is an intrauterine contraceptive device which has perforated, I think. Yes, sir.
Okay, let's check. Is it intrauterine or extrauterine? What do you think?
Yes, sir. Yes, sir. I think it is not. Yes, sir, it is not inside the. It is not inside the uterus. It is perforated the uterus, and it has now it is lying in the peritoneal cavity.
Or what
I
do you
would like.
think? What's your diagnosis?
Sorry, sir. So this is uterine perforation, sir, with perforated intrauterine contraceptive device lying outside the uterus, and this is an emergency. We'll need urgent laparoscopy retrieval and urgent referral
Why
to the.
why emergency? The patient has chronic pain. Why emergency?
So because this can lead to peritonitis, sir, this is long, if it keeps standing there for long, it can lead to peritonitis, or it can migrate, or it can perforate the surrounding bowel loops. So because it is a metallic device, it can cause perforations or perforation of the surrounding bowel loops.
Okay.
It may.
Okay. Okay.
Yes,
Thank you. It
thank
was a
you.
very tricky case. What is the advice from this case when the examiner give you a slice and they are telling you concentrate here and not trick you, he not confusing you. He is trying to help you. Why? Because according to the marking process, he have some steps. Number one, to let you freely answer. Number two, to initiate or to stimulate something to help you. Number three, to help you frankly, like this. Please concentrate here. Okay. And when he telling you like this, hmm, yes, when he telling you like this, please follow his answer.
Simon, चौथा बजे का ऐसा भी करें मुझे दे देना
Please, my colleague,
चौथा बजे
mute yourself.
बाहर जा
Okay. So, I bring this case specifically to insist and to advise you follow the examiner. 99% of them, he will help you, even aggressive examiners. This is not from his own. This is the RCR laws. Again, he must first allow you freely to answer, then with little help, then with maximum help. And at each level, you have a different marks. Maximum help, he fair, he يعني hardly may pass you like this. Okay. Number two, in MRI, we have very big problem. Classification, foreign bodies, okay, is very hardly to be detected. At least you can say, Doctor, I see here dark linear signal. At least, okay. I don't know what is this. It may be foreign body, maybe something else. I wanted to revise all the image or X-ray or CT. So there are an advice, especially in practice, many centers when the technician request MRI joint or any MRI MSK especially, they ask to do complementary X-ray, facilitate the reporting process. See here, see, very easy, very classic, even from the scout. Okay, migrating IOD outside the uterus. If you looked here, this IOD, I think, as you see, didn't cause any IO, spinal obstruction. And in the MRI and CT, it didn't cause any hemorrhage. So, and the patient has long-standing pain. So I think this is not urgent, okay? Because it is very important. Urgent in NHS means almost life-saving. Okay? Thank you, doctor, so much. It was very tricky case. Next candidate,
Yes,
please,
hello. Assalamu alaikum.
welcome. Also, request control, please.
Yes, doctor.
1 second. I think I missed 1 second. 1 second. I leave the mouse last. Please. I think we are. Oh, actually, I just check. If we are recording. This
I will,
patient is request control, please.
okay.
25-year-old male patient presented with uh, diplopia, uh, abducting nystagmus, and ophthalmoplegia. Go on.
Diplopia, nystagmus, and internuclear ophthalmoplegia. Okay. I am presented with T2 axial images of a 25-year-old male who has presented with diplopia, nystagmus, and internuclear ophthalmoplegia. I will just scroll through the images and then give my findings. So I am looking at the orbits. I am looking at the cavernous sinuses. As well as the midbrain. Can I review other orthogonal planes?
Yes, sure.
Oh,
All
okay.
are all are axial, but
All
there
are
are MRA,
okay.
gradient, and diffusion.
Okay. So in the MRA images, I'm following the vessels. I can see that there is a connection between the right internal carotid and basilar. This is persistent trigeminal artery. I want to review the D2 images again just to see the course of the optic nerve, because persistent trigeminal artery can cause compression on
Leave
the
the mouse.
adjacent nerves.
Leave the mouse. Leave.
Okay.
Oh,
I
choose.
can
Yeah, choose. Okay, this one. Go on.
I'm unable to appreciate the persistent trigeminal in these cuts. Maybe this
At
one.
this level. Yes.
Yes, this one.
Yes.
This one.
So,
This one. This one.
okay. Yes.
So this is the expected location of, I think, the ophthalmic nerve, abducent
Ophthalmic.
or abducens nerve. Abducent,
Okay.
ophthalmic.
What is the ophthalmic nerve?
The trigeminal ophthalmic division of trigeminal nerve.
So is the ophthalmic nerve has
No,
any relation here?
no.
So
The I forgot the name of the nerve.
yeah. How many?
Abducent.
Yeah, maybe. Okay.
Third, cranial of three.
No. From
Four.
what is the exiting site of the third cranial nerve?
Hmm. I
What
completely
what is
forgot.
what is the name of this level?
This is at the level of midbrain.
Midbrain? Are you sure?
Uh, Pons, Pons
And
midbrain, like at the level of,
lower midbrain. From
yeah.
where the oculomotor or the third cranial nerve originate?
They originate from the midbrain.
Where?
In the interpedunculaire, like in this
Yes.
region.
Yes,
Yes.
very characteristic. The only cranial nerve that arise from anterior.
Yeah.
Okay. I say to you, you can't detect here because this brain is not high resolution for Rabelais stem.
Yes. Assess image would be more better to characterize the
Yeah.
exiting nerves.
CISS,
Yeah.
which is
Heavily weighted T2.
fluid sensitive, high resolution. But
Yes.
see here at this
Here.
level,
Yeah.
yeah. Okay.
Okay.
So this trigeminal nerve may best to detect here. See this better.
Yes.
This is the primitive trigeminal arch. Okay, and this is
Yes.
the bones. Very clear. Okay,
Yes. Yeah.
go up. This is the midbrain.
Yes.
Okay, what is the function? Sorry, what is the function of the primitive trigeminal artery?
So it is a communication between the anterior and posterior circulation. And
Yes.
sometimes it can be the dominant blood supply to basilar artery distal to its connection to it. So it can
Do you know?
be,
Do you know exactly the exact anatomy of the internal carotid side? From which part of internal carotid artery does it originate?
I think, the cavernous, petrous or cavernous. Hmm. I
Hello? Again,
Hello, yes.
please.
I think Petrus or Cavernous, one of them, like
Yeah,
Petrus or
between Petrus and Cavernous.
yes,
Petrus and Cavernous. Okay.
yes, yes,
This is the Cavernous part. Okay.
yes.
Before it is the Petrus part.
Petrus. Yes,
It's just between of them. Okay.
yes,
Why
yes.
does this some one candidate ask? It may be posterior communicating. Is it
Uh,
this one? Why? Why not or why yes?
Posterior communicating usually arises superiorly at the level of circle of Willis, and then it
Yes.
is communicating to the posterior cerebral artery rather than the basilar.
Excellent. Thank you, doctor, so much. Do you know, last question, the most common sign of the
Uh,
primitive trigeminal artery?
the Taw sign.
Excellent. But it is better seen in sagittal. Tau
Yes,
sign, it is tau, I think it is Japanese or Chinese letter or figure. Thank you, doctor, so much.
thank you.
I will show you, my colleague, what is tau sign, but it is better, leave the mouse. Uh, the answer was persistent primitive trigeminal artery. During the embryogenic life, the posterior circulation is supplied from this artery. Okay, direct connection between the internal carotid and the posterior circulation, exactly to the basilar artery. And this is a very big difference between it and the posterior communicating. Why posterior communicating is a connection between the ICA and the BCA, posterior cerebral. See, my colleague, this is the tau sign. I will show you. Look here, this one, like this. This is the tau figure. Okay, this is the actual anomaly. Okay, my colleague, but it must be seen in sagittal. Thank you, doctor, so much. Next candidate. This case my colleague, by the way, demonstrate again and again the importance of asking for other MBR, asking for other sequences. Okay, if she didn't ask, I will not give her this sequence. Next candidate.
Yes, good
Doctor, this is
afternoon.
25. You're welcome. Ask control. This 25-year-old patient referred for evaluation of right breast lesion and the painful bony lesions. Go on.
Iris scroll. I have been provided with the HRCT. I will scroll through the image and then I will start to comment. As regarding the lung parenchyma, I couldn't see any abnormality, any pulmonary nodules, or any consolidation, any mass lesions. But I can see there is multiple lytic rib lesions, so I want to see these lesions in the bone window to fully
Yes,
comment on their
take the bone
nature.
window. Take the bone window.
Okay. This sagittal bone window view of the chest. I, I can see multiple lytic lesion is seen involving the dorsal vertebrae and involving the posterior element of the vertebrae and also multi-level of the ribs. And I can see also there is multiple enlarged axillary lymph nodes. Actually, the image is jumping. So as regarding a patient of right breast lesion and painful bone metastases. So I'm suspecting to be a neoplastic lesion within the breast with multiple bone metastases. For this patient, I will ask for ultrasound evaluation of the breast, and I will and then I will ask for as regarding this maybe neoplastic lesion with lytic metastases. I will ask for CT chest, CT abdomen and pelvis for different location of metastases. And I
Yeah.
will refer the patient to local breast cancer center for further management.
See, doctor, do you think do you think this lesion is metastasis, or would you add any differential diagnosis? Look here. Would you think metastasis will be very polite like this, very gentle like this?
And also I can see some steroid
Mm-hmm.
matrix inside the lesions,
Mm-hmm.
especially this within the ribs. So my differential also may involve um, osteochondroma.
What else?
Also,
Mm.
maybe fibrous dysplasia.
Okay, what is your next step?
Um, I'll ask for breast ultrasound.
Why first ultrasound? Okay, what happened here?
With MRI. I presented with MRI T2 on the spine, sagittal plane. I can see there is multiple hyper intense signal within the dorsal vertebral body, and I can see there is vertebral collapse seen along the mid thoracic vertebrae.
Mm-hmm.
Yeah.
Yes,
And also,
but this vertebrae is collapsing. What do you think?
yes,
What's your final diagnosis?
mm, vertebral collapse, maybe LCH can cause vertebral
Okay.
collapse, but
Do you think to do any investigation or to revise anything?
it,
Mm. Okay. Okay. See,
this
even
bone is
by the bone scan, all of them are metabolically active. There
it,
is this uptake. What do you think? Do you want to do something or revise something for this patient?
this may be hyperparathyroidism.
Maybe. What is your next radiological or generally, what is your next step?
Actually,
Only one exam will help you, will help you very
sys-
simple. Hmm.
system system scan.
Systemic scan? Why?
Yeah. So if it is hyperparathyroidism,
Hmm.
I'll, this is likely to be fibrous dysplasia.
Look here. What happened there?
This ground glass
Yes.
appearance of the mandible and the base of the
Yes.
skull.
So what's your final diagnosis?
So this is a case of fibrous dysplasia.
Which type of
And
fibrous disability?
the polystatic fibrous.
Yes. What is your next further investigation or further steps?
For a patient of fibrous dysplasia, يعني no further steps if the patient is not complaining. But as regarding the vertebral collapse, I will check the spinal cord again for any
What else? What else?
compression.
Okay, what else? What is
Actually,
the most? Yes.
fibrous dysplasia may come in syndromatic.
Yes. Okay. What is the name of the syndromes?
Here, I will look for soft tissue to see any soft tissue calcification, and I can see soft tissue. So I think it is um, Maffucci syndrome.
Okay. What else?
They also come.
By the way, Maffucci syndrome
لا,
is
not
not
Maffucci, not Maffucci, not.
yes, and there
I'm
are
sorry.
no any soft tissue calcification.
I'm
So,
sorry, not Maffucci. I think McQueen-Albright syndrome. Not
okay. What is the other syndrome?
Mazabraud and McQueen-Albright.
Okay. Thank you, doctor, so much. My colleague, today, today is a session about how to ask about the previous examinations and about the NPR specifically. Okay, why? In the last case before migration of IOD, if our candidate ask only for X-ray, he will get the answer immediately. Okay, I think this one. Here also, the same. If he asks for either mandibular CT or X-ray, see, very clear. Fibrous dysplasia is one of the very, very confusing diagnosis in MR. Very confusing. Even see here, yeah, I think this one. Very confusing. Why it looks like soft tissue mass. See, really, you can't be 100% sure either this myths or no. Despite there are sclerotic rims, there are no extra osseous extension, no distraction, but actually, in practice, most of us will ask about the past history, about X-ray. So again and again, it is allowed for you when you are confusing with something to ask about, especially primary primary examination like X-rays, Okay, it is very very helpful. So ask. Okay, my colleagues, this patient, even here, if you have a look at the breast, I think no any obvious thing, but this is the non-contrast. Overall, the breast looks like normal. Okay, even no pathological lymph nodes in both axilla. Anyway, again and again, ask for old or primary examination like X-ray, ask for MBR to avoid any tricky cases, to avoid any confusing cases. Thank you, doctor, so much. Doctor, I have one
Thank you.
advice for you. The examiner
Yes.
have two parts during examination. Number one, he wants from you to answer the case that he presenting to you. Number two, he sometimes wanted to test your knowledge. So when you reach the diagnosis, try to give him as much as possible related knowledge and theoretical information. Like, doctor, looks like polystotic fibrous dysplasia. I will do one, two, three. I will exclude one, two, three because it may be syndromic for one, two, three, like this. Like this style, they love too much. I think the examiner gave me an X-ray in my Viva, only X-ray knee, and it looks like there are sclerotic lesion. Within the X-ray, I describe everything for him in MRI, in nuclear scan, In management, I think he didn't give me the next examination like this because everything he will ask about it, I answer before he talk. Okay,
Yes. Yes. Thank you.
thank you, doctor. And don't wait the examiner until he asks you what else, what is the next step, what does it mean for you, any syndromes associated with this disease. Okay, thank you,
Okay.
doctor.
Thank you. Thank you.
In cold cases, my colleagues like this uh, think is it syndromic or not. In urgent cases, think it is it life saving or not. Okay, next candidate.
Assalamu alaikum.
Wassalam. Doctor request control. This is 60-year-old female patient presented with 4 days of right iliac pain and fever.
Right. Okay, sir. Um, so I am provided with a frontal radiograph of the abdomen, in which I can appreciate multiple dilated small bowel lobes in the center of the abdomen.
Yes.
There is no evidence of pneumobilia noted.
Yes.
No evidence of any pneumoperitoneum.
Yes.
I am looking for any surgical sutures, which I cannot find. However, there is a density noted in the right hemipelvis. There is a tube which is external on the right side of the film. So I am looking for the hernial orifices which are visualized. So on this visualized X-ray, I cannot appreciate any bowel loop or any lucency below the pubic symphysis.
Mhm.
I am suspecting if this small bowel obstruction is due to this opacity, for which I will ask the history of the patient. If I will correlate it with any previous imaging if available, or
Mhm.
previous imaging of the pelvis if it is available.
Okay.
Second,
else?
I am suspecting, I will ask the history of any previous surgery because this could be due to adherence.
Okay. This is your next step.
I will convey my findings of a small bowel obstruction to the referring physician and recommend CT abdomen with contrast to rule out the cause.
Listen. What's your diagnosis?
This is the scanogram. I can appreciate lucencies over the liver parenchyma, which are linear in structure. However, there is no evidence of pneumoperitoneum. There is paucity of air in the rectum, so rectal
Mhm.
area. This opacity or this density in the right hemipelvis it could be a gallstone which is causing the small bowel obstruction. I will confirm it on the CT scan.
Mhm. See, this only the available image just out because the patient, sorry, the technician by mistake deletes the rest of the sequence. And the surgeon want to take a decision. What's your final diagnosis?
On the scano.
Yes.
Okay. So I am again looking the whole scanogram. I again demonstrate these linear lucencies along the right upper abdomen. No pneumoperitoneum, no suture lines, no metallic lips. No, I am looking for the hernias.
So
I
what's
cannot
your
appreciate.
final diagnosis?
Final diagnosis so far is the same, the small bowel obstruction due to the gallstone ileus.
Okay. What does it mean, this lucency? You didn't inform me.
These lucencies are within the bile ducts and causing the pneumobilia, which is due to a fistula between the gallbladder and small bowel lobes.
Okay. What is the name of this fistula?
Sorry, sir.
What is the name of the fistula?
Um, uh, Coloenteric fistula.
Okay. Okay. Oh, cholecystoduodenal fistula. Okay.
Okay, this is
Thank you, doctor, so much. What happened here? Here, look here. In X-ray, don't expect that the lucency here in the pneumopilia will be very clear. Look here. This is the lucency here. Okay.
yes, sir.
This is one. Okay. At least those. So don't judge. Don't judge. There are no there are no pneumopilia before zooming. And by the way, my colleague, zooming is allowed without permission in the vive. Don't ask the examiner. But he very happy. He became very happy when you are zooming. Why? Because zooming means this is your actual practice. So you must zoom first, or ask me because we didn't have tool here to zoom. And look here. Number two, you find a stone here or a radiovesti here and dilated bowel. Search here for any lucency and tell the examiner there are linear lucency, branching lucency, almost representing and towards the center of the liver, always representing pneumopathia. Why? This is looks like a picture of gallstone ileus. I told you many times before Viva and oral examination, sometimes depend on guessing and expectation. Okay.
Okay.
Sure, there are CT, but in very simple cases like this, he will not give you the CT. Okay, because it is very simple. I think okay, it was very clear. Look here,
Yes, sir.
doctor, how to differentiate between portal gas and pneumobilia?
Porter gas is usually within the periphery of the liver, within 1 centimeter, and pneumobilia is in the center of liver parenchyma.
What is the name of the disease if the stone is stuck in the duodenum?
Bovert syndrome,
Bovert syndrome. Okay.
like this.
Bovert syndrome. Okay. Bovert syndrome. Thank you, doctor, so much. Next candidate.
Yes, yes, doctor.
One, second. This patient has a numbness of his left. She is 40-year-old female patient. You can request control. She is complaining of numbness of her left face. Go on. Request control, please.
Request.
Yes.
Is this middle age presented with axial CT scan of the brain in bone window for a middle-aged female with left side numbness of the brain? Okay.
Of the face.
Okay, I am scrolling through the images. Sorry, it's very slow. I'm scrolling from down upward, checking for any major abnormality before commenting. I can see the okay, mastoid hair cell. Sorry.
1 second, 1 second.
Okay.
1 second. Leave the mouse. Leave 1 second.
Okay.
Okay, go on.
Okay. I can see the mastoid hair cells, they look clear. Middle ear cavities also. Middle cranial fossa. It's not scrolling. Okay. Skull base bones look fine. The mandibular fossa also. The left side swelling. Okay, so
Where?
I'm just remembering the history. I'm trying to scroll. Um, Actually, I see bilateral soft tissue swelling here.
Where?
I'm not sure.
Where?
Here, both
No,
sides, but it's bilateral. It doesn't
this is
look like
normal.
because they are symmetrical.
This is
Okay,
normal.
okay. The orbits in bone windows, they look fine.
When the patient has left hemifacial numbness, what does it mean for you?
Uh, Numbness. I should be searching for cranial nerves on the same side,
Which
left side
cranial
for
nerve?
uh,
Hmm?
facial nerve, trigeminal nerve numbness. I have to check for
Okay, okay.
the
But the
neural.
patient, but the patient, okay, you're right. But the patient after examination, he has some weakness in his left hemiface. He
Weak.
didn't describe his complaint. The clinician sent us a note that he has some weakness in his left hemiface.
Weakness. So do we have? I have to check the facial nerve on the same side. Uh, okay. There's it's not scrolling.
Let me scroll for you. Let me scroll.
Okay, he's okay. It's still working. Yeah. There is. Oh, so can go back. Sorry.
Mm. Leave them out. I will go back.
Okay.
Mm.
I thought I saw something.
Okay, what is your next step?
I will
The
check.
clinician insists that he have some doubts about the
Yeah.
left facial nerve.
So I cannot see any abnormality here on this
What is your next
CT.
step?
So I will go. I will go to directly to
Leave them out.
MRI.
Okay, leave
Yes.
them out.
Okay. Heavy to MRI.
Okay. This is MRI. See, go directly. This
Fish.
MRI brain. Go on.
Okay. I will check the facial nerve from the bones. Okay. Brain. I looks unremarkable. Gray with method differentiation. No hydrocephalus. Yeah, this is the vestibulocochlear nerves. They look fine. I will, it's just below the vestibulocochlear nerve. Um, Actually, I don't see
Do you think
any
this is the
abnormality.
best? This is the best sequence to assess the CB angle and the Petrus one, or you should use another sequence?
I should use this HVT2 weighted sequence for
This is
assessment
the
of
name.
the cranial nerves. Cis sequence.
Okay. So ask the examiner.
Yes. Okay. Okay, this is a
Did you find anything?
yes.
Well,
No.
yes, where?
No, I didn't find until now. I'm trying to search.
Which sequence do you want? When you are stuck in Petra's case, practically, which sequence you wanted to use to roll out or to prove anything for the facial nerve or cranial nerve number 8, vertebropatellar. In your practice, which sequences? Only one. Choose one.
Petrus.
You, you
I
wanted
think the
to
diffusion. If
diffuse.
diffusion
Okay,
okay,
this
to
is diffusion.
exclude cholesterol.
Okay.
Okay, let's go back. Can see there is hyperintense signal here.
Where?
The
Where?
diffusion restriction here. Here, this one.
Where? Show me by the mouse. You have the mouse.
Here. Yes, it's here by the mouse.
This one.
It's not
This
shown.
one? This?
Yes,
Where it is?
I think
Where?
it's in the Petrus apex. I think.
No. See, the Petrus apex is here. Hey, leave, leave, leave.
Oh,
The Petrus
okay.
apex is right here. Hmm. What else? See, I will help you because you chose the wrong sequence. Why? Because until now you didn't know or you didn't define what is where exactly
The
the
abnormality.
pathology. Okay, one second. So diffusion is used after knowing where is exactly the pathology because diffusion is of low resolution. So it is very, very poor sequence to define any anatomical details. But if you use this one, did you find anything? Look here.
Post contrast.
Did you find anything at the left side? Compare right by left, please. Compare right
There is
by left. Hmm, What happened?
there is dissection flap here.
What?
Okay, I'm not sure of this.
There are any discrepancy between right and left? Any difference? Look here and look here. This is the nerves. This is the nerves. This is
There
the
is
larynx.
hyper
Yes.
there
Where?
is hyper enhancing lesion here.
Left or right?
Left uh,
Yes. So what does it mean for you?
hyper enhancing lesion in the auditory canal. I think with the patient facial complaint, so it could be facial nerve schwannoma.
Excellent. What is the exact location?
It's there is a ganglion, facial nerve
Yes.
ganglion. I don't remember
Yes.
its
What is
name.
the name of this ganglion?
Geniculate, I think. Geniculate, I think.
Excellent. Excellent. Thank you, doctor. Thank you. It was a difficult case, but take some messages here. When you is presenting with this case, please try to use all your skills. What happened here? Sorry, doctor, I will give you some advices, not something offensive. Um, the first, I bring to my colleague this city to make the case more difficult, by the way. Okay. Then I give her a misleading history. She did very well in the beginning when she talked about here the Michaelis cave. I think this one exactly here, and the course of I think more above. By the way, no any bony erosion would be related to the trigeminal. Okay, this is until this you were very right. Then I change the complaint to a facial weakness. Okay, so we must examine both internal auditory canal for any asymmetry. I think both of them are symmetric. Okay, but we must follow the rest of the facial nerve. Which most of us didn't do. If you look here along the medial wall of the middle, this is the middle by the way. Why? Middle auditory canal. Why? This is the osticle. So this is the middle. The facial nerve, look here, my colleague, enter
Yes.
and then come here for the geniculate canal. All of this is the facial nerve, by the way. He run along the medial wall. Look here for the normal one. This is the normal one. Run along the medial
Yeah.
wall of our medial aspect of the middle auditory canal or middle ear. What happened? This is MRI. From the beginning, you must ask for this one. I think me ask for
I
siesta,
asked it
fiesta,
already.
cube. Yeah, no. For the beginning, I give you this and you examine. You start to see. No. From the beginning, ask for magnified view, high resolution view of the bitrate like this. Okay? From the beginning.
Okay.
Why? The examiner want to assess are you do a lot of practice or not. If you look here, my colleague, follow how to follow the facial nerve. Go to the
Just
CBI. Yeah, this is the facial and this is the eighth cranial nerve. Follow facial nerve until here it is completely normal. And then follow here, the AB oblique segment of it at the geniculate ganglion and medial wall of the middle ear. I think there are here some soft tissue not seen here. I'm not sure. I'm not sure, doctor. Give me the post control. So in the facial nerve, if you wanted to rule out, there are only two diseases for facial nerve, to be honest. Either schwannoma or either neuritis. The post contrast is very diagnosed. See, very obvious there are something here, even if you don't know the segment. Very clear. Is it clear?
Yes,
Is
now
it
clear.
clear?
Yes.
See, by
Yes,
the
yes,
way,
doctor.
my colleague, what again and again, every session I repeat this phrase. I'm trying to bring the cases that you will not um, think about it out of the box. A typical scenario. Okay, why? All easy cases or repeated cases, you will answer 100% even in the exam. And by the way, more than 60% of the cases are repeated and very clear. But the examiner is very intelligent. Every examiner, he give you the weight of the exam or his assessment mainly concentrated or centered in the difficult cases. I think many of our colleagues give me a feedback about when I ask them this June and September last September, what is the most difficult? Some of them told me, Frank, by the word, they bring us a typical spine case. See, we are not familiar with spine. How come they give us a typical? And this is the right. Why? Because you are examining for FRCR, which will make you a consultant in NHS. Comparison in I, comparison in CBA, comparison in Petrus is very important. Okay, my colleague. If you didn't compare, you will not detect the pathology. Okay? One of the
Okay,
most common pathological site of the facial nerve is this one, the geniculate angle. How to detect this? Bring the post contrast, and then you will see very clearly this semicircular canals. Okay, anterior to it, anterior. This is the course, and even here in the internal auditory meatus, it is very easy to pick up any pathology. Thank you, doctor, so much. What is the diagnosis again? Facial nerve schwannoma. Which part? Geniculate part. The facial nerve have 5 or 6 segments. It is very important for all of you to know all of it. Uh,
thank you.
Doctor, I have question.
Yes,
Do you think the intracranial part of facial nerve normally enhanced or not?
intracranial part. Uh,
Yes,
I don't
because
think.
see, what is the segment of the facial nerve? This is the cisternal part or intracranial, then the canalicular part, then I think labyrinth side, then another two parts. I'm talking about this intracranial part. Normally enhanced or not?
Uh, no, I'm not
Hmm.
sure.
Yes or no?
If there
Enhanced
is
or
a
not?
lesion,
Normally,
no,
normally
I don't
enhanced
know.
or not?
No, I
Normally
don't
not
know.
enhanced due to the
Yes.
brain-blood barrier. So when you find any enhancement of the intracranial part, I mean intracisternal part or even the intracanalicular part of facial nerve, think about neuritis, especially if this enhancement is uniform. Thank you, doctor, so
Okay.
much. Next candidate.
Yes, doctor.
Doctor, this patient came to the AR comatose with a vague history, and the ER doctor, as a routine workup, asked for chest X-ray.
Okay. I'm presented with frontal chest X-ray image. I can see that there is right side of the chest diffuse view opacity. I can see that the lung is collapsed with a deep sulcus sign. This is be suggestive of right-sided hydropneumothorax. I can
Yes.
see that the mediastinum is central in position. I can see two radio opaque dense shadows, one overlying the spine and one overlying the right lung. They could represent they are foreign bodies. They could represent like gunshots. I would like to do CT chest with contrast for the patient. Um, I can see that there is right chest tube inserted. There is
Yes.
a right-sided hemothorax.
Yes.
And with the I would like to check lung window, of course, to check for the pneumothorax. There is still a residual pneumothorax and surgical emphysema.
What
Um,
else? What else? See,
uh,
advice
I
for you
I can see
before
lung
before I
confusion.
forget. Before I forget.
Yeah.
When you are shifting from chest X-ray to CT and you are finding the same finding without a big change, just tell one word or one phrase. The CT confirm the previously mentioned X-ray
Yes,
finding, and then search for another big disaster.
yes,
When the examiner follow you and he give you the CT, it
yeah,
means there are something new. What is
yes,
the new here?
I can see that the foreign body is seen overlying the mediastinum, and there is contrast, oral contrast in the esophagus, which
Yes,
is leaking at the posterior mediastinum.
yes. What does it mean?
Esophageal injury and
What is this?
this is hemorrhagic contusion of the lung.
Okay, hemorrhagic contusion, and what is this air?
A fistulous tract with
Why?
uh,
Why?
the course of the pullet.
Yes, yes. So give me a final diagnosis.
This is a patient of post-gunshot with right-sided hemothorax and pneumothorax with chest tube insertion and esophageal tear and I would like to to assess vascular structures in a contrast study if available.
Okay, what else?
Um, mm, I'll
What
check bone
else?
window for any bony fractures.
Okay, what about this injury? What is your next step? Must concentrate it. Okay, you give us something
I
about
will
the
refer
vessel.
to surgical team for
Hmm,
esophageal repair.
very. Thank you, doctor, so much. Take
Yeah,
one home
thank you.
message. You
Thank you.
mentioned here the mediastinum is center, not acceptable at all. The mediastinum contralateral shift. Next, you mentioned there are two opacity which may be contrast. No, not contrast at all. The contrast will not like this
No,
will
I didn't say contrast. I said radio big objects that could be gunshots. I didn't say contrast. No.
sure. Okay, I'm sorry.
Yeah. It's
So this case learn us, educate us how to guess. Guess how to guess. Very important. Why? Foreign body here and contrast extravasation and the track. Okay. The examiner will not tell you some histories because if he told you, he will give he like this, he will give you the answer. This is the short track. How could we know? Looks like contusion plus air, but it is a track. And if you follow, you must find the foreign body, like here. Okay. Okay, my colleagues. So this is the philosophy of gunshot. One body, and if we have more and more MBR images, we can see any opening or any cut in the skin, which mean entry of the gunshot track and the foreign body. And sometimes you will not find the foreign body, you will find exit. Okay, so it was a gunshot esophageal rupture. Okay, my colleague. Thank you, doctor, so much. Next candidate.
yeah.
By the way, my colleague, by the way, really, I don't know the list. I bought the cases randomly because some cases looks like very sophisticated. Okay, and some cases looks like straightforward. Okay, but the philosophy of my session is to pick up something to educate some advices. The last case of the gunshot, to guess how to guess. I didn't give her at all any history. I just told her a vague history. By the way, some examiner will told you like this. He wanted to assess your imagination because, as all of you know, radiology needs a lot and a lot of imagination. Next candidate, 40-year-old female patient complain of severe bleeding. Case of today.
Yes, sir.
Go on. um, Go on.
Okay. Okay. I'm presented with uh, MRI images of a 40 years old female with severe bleeding. On axial T1, I can see a hyper intense lesion in left adnexa.
Yes.
Another hyperintense multiloculated lesion is also seen in right adnexa, which has some locules hypointense and some are hyperintense.
Yes.
So both, sir, I would like to compare them on T1 fat set, please.
Choose. Select yes. Okay, go on.
Okay. On axial T1 fat set, they still appear hyperintense. They are not suppressed. I would like to see the uterus. Here is the uterus. Okay. Uterus is not very clearly delineated. There is another linear hyperintense tract between these two lesions. Okay. Sir, can I see T2? Coronal T2?
Yes, go on.
Okay. Okay. There is some delay. On T2, the larger lesion on the left side has hypointense wall with internal hyperintensity and some hypointense nodules in its wall. And the right-sided lesion has seems to be ovarian right-sided lesion with multiple hyperintense small lesions, likely hemorrhagic follicles. This can be most likely hemorrhagic follicles. However, I would like to see the images on contrast. The endometrial cavity is filled with fluid, and there is some free fluid also in the pelvis.
Are you sure this is hemorrhagic?
Sir, I would like to see fat sensitive sequences.
Already see, doctor, one sec. Already you saw.
Sir, is there any
Yeah.
contrast enhance? Can I see contrast
No,
enhance?
suppose that no contrast enhancing. No, not.
Sir, this can be pus
Already you see,
proteinaceous content.
one second. Already you saw this one.
This is all
Okay.
automatically scrolling. Yes.
Okay.
Yes.
And then you scroll this. So what's your concern or what's your diagnosis?
So based on these imaging, the primary diagnosis is endometriomas, bilateral ovarian endometriomas, since they do not suppress on fat. However, the differential also include any ovarian lesions containing pus or high proteinaceous contents like abscesses. Sometimes they can also present with high intensity material. So since the patient's history is bleeding.
Clue. One second. Give me one clue and one final diagnosis.
On this sequence?
Only one of them.
Okay, sir, can I see contrast? Can I see contrast before I give the final
Is this
diagnosis?
clearly? Is this lesion? Is this lesions? Look here.
Yes, there is a
material or
fluid level.
endometrioma. And why?
So there is a fluid level with the hypointensity on the base and hyperintensity on the top. So this is most likely endometrioma.
What is the name of this sign?
T2 shading sign, sir.
Okay.
T2 shading. Yeah. So these are bilateral ovarian endometriomas.
What else? Before I advise you, very golden advice. Do you remember it?
To change the sequence, sir, can I?
What
can
else?
I see
No,
this?
no. I'm see one of the golden words. Don't trust in the examiner when he giving you something very clear.
Yes.
Correct?
Yes.
Don't trust me, please.
Okay, so I would now again review my findings. I would like to see any other endometriomas, endometrial deposits in the pelvis. Here I can see the tethering.
Yes.
At the junction of the bowel and the uterus. So this can be an endometrioma deposit.
What is the name of this sign?
So mushroom sign, maybe when there are deposits at the
okay, but
junction.
mushroom sign not seen in axial specifically. This sign has another name. Tethering. This tethering. What is the name? What is the name?
Sir, I forget. Sir, I
Tethering
forget the
of
name.
what is this structure?
Sigmoid.
This is the two both of it. when both ovaries are intimately related to each other, what is this sign? There
Kissing
are two
ovaries.
signs here. This kissing ovary.
Kissing ovary
Great.
sign.
And what
Yes,
is the name of
and
this sign overall?
clover leaf sign. Clover leaf sign.
Great. What's your final diagnosis?
So my final diagnosis is deep pelvic endometriosis with endometriotic deposits in the
Which
cul-de-sac.
structure, which structure do you want to rule out if it is affected with endometriosis or no?
So, it can be bladder
What
and
else?
broad
What
ligaments
else? What else?
and bowel, bladder, broad ligaments, and anterior
Once,
abdominal wall.
no. Once bowel already affected. This
Yes,
clover sign means the bowel is affected. What else?
yes. So I would like to see urinary bladder on T2 and anterior abdominal wall in these sequences. Does it
Yes.
show
Anterior
any?
abdominal wall. Very
Mhm,
common, the rectus.
mhm.
Thank you, doctor, so much,
Yes,
by the way. Let me give
please.
some notes. My colleagues don't trust the examiner when he gives something very obvious. Okay, start, describe, squeeze the case, match the case, and after that, think what behind. What is the disaster behind? Especially if this is a final case, closing case. Uh, start start case is almost very easy and very quick, but closing case almost not easy. What happened here? There are a T2 shedding sign, okay, which a sign of chronic repeated bleeding. So in the bottom there are hemosiderin. In the other levels, this considered a blood product. So it gives different degree of gray shadowing or signal. So this is the T2 shading sign. Very, very characteristic of endometrioma. And this is a very good differential point between hemorrhagic. Hemorrhagic means one stage, almost subacute, and almost will be high T1 and low T2. Sorry, if acute. Oh, sorry. If early acute. Or high T2, high T1, or late if late subacute. But T2 shading means chronic repeated hemorrhage. This is a sign. After telling the examiner all of this, search for deep infiltrating endometrioma, and you will not find it almost as a direct sign. Search for kissing ovaries like this. Both ovaries are intimately related, abutting each other due to fibrosis, which results from the deep infiltrating endometriosis, best seen in this coronal. In axial, search for affection of tethering of the rectum or colon, like here, and see all of this. This one is deep infiltrating in endometrium. There are very common area here called uh, tuberosiranis. This one here at the uterocervical junction. This is the point of origin of uterosacral ligament. So if you look here, there are a mass here, very dark mass. This is deep infiltrating endometrioma, and this is the mushroom sign, by the way, better seen in sagittal. And one of the very common locations, the rectus sheath. I had been presented with a case like this in my MD in Asia. After 2 hours of oral exam, the examiner gave me only one MRI with one lesion here. I enumerate everything, but I forget to tell him endometriosis. And it was endometriosis. It was here in rectus muscle. Okay, my colleagues, thank you for all of you for your attendance. Thank you so much for our coordinator. Again, my colleagues, most of the cases that I am presenting to you is final cases. You can consider final cases, which is not easy. So for our colleagues who didn't answer well, don't worry. Don't worry. This is very difficult, tricky, confusing. Repeat the record again and again. The Viva need a lot of effort and some luck, by the way, to be honest, to be honest. But we must do our best. Okay, my colleagues, thank you so much. Goodbye.